Good evening, everybody. It's my pleasure to welcome David Jenkins, a consultant microbiologist from down the road in Leicester, who is also chair of the Microbiology Standing Advisory Committee for the Royal College. Tonight's topic is PPE, which has featured in the news for many reasons, I think I won't anticipate what David's going to say. I'll simply hand over to you and you can take over the screen and then I'll quiz you afterwards.
Well, thanks very much for the invitation. So I've been asked to give a presentation on personal protective equipment. Let me just... So my day job as consultant medical microbiologist, but most of the time I spend doing infection prevention. And when we normally think about infection prevention, we think about preventing infections in patients. But it's also really important, and a very important aspect of IP is to protect staff as well. So let me just see, can I get to the next slide here? So how do I, it's this button, which is the next button. Right, so this is interesting. How do I advance? There we are, press up on there to advance the slides. Right, good. So this is what I'm going to be talking about, COVID-19, the risks to healthcare staff. I'll go through some of the legislative and regulatory requirements, but with the caveat that I'm not a lawyer, so don't take what I'm talking about tonight as good legal advice. You need to consult a proper solicitor about this, I guess, if you find yourself in difficult circumstances. I'll also mention a little bit about aerosols and aerosol generating procedures, and then followed by some respiratory protection, which is really the most important element of PPE when it comes to things like COVID-19. But I will mention a little bit about other types of PPE as well. So generally speaking, healthcare workers are continuously exposed to the risk of infection. This is a nice graph from the Office for National Statistics. I've taken quite a few things from there for this evening's presentation. But what it shows on the horizontal axis there is a measure of physical proximity to others in your job. And it turns out artists are the most remote professional group, so they spend very little time with other people. Whereas doctors and nurses, right up the right-hand side there, have a lot of spend a lot of close contact time with patients. And going up the vertical axis, it's the kind of the proximity of contact with people as well. I think the only group that's got a higher risk in terms of contact and proximity of contact, duration of contact, is dental nurses. But doctors, nurses, nursing auxiliaries, and there's about 1 million people in this country in that category. And so perceptions of risk have been heightened by COVID-19. When you're involved in infection prevention on a day-to-day basis, you see this risk much more frequently. It's a very daily problem. But most people spend their lives blissfully unaware of the kind of exposures they're getting. And you'll have seen in the newspapers very tragic deaths of UK healthcare workers. Over 200 UK health workers have died reportedly from COVID-19. Although it needs to be we need to remember that not all of this is necessarily through occupational exposure. And clearly, we have families, we go out, we go shopping to get food and so on, and we're all exposed to the risk of transmission outside healthcare as well. And it's not just from patients, but I think an under-recognized risk is transmission between staff, so staff-to-staff infection. We've had a number of little outbreaks in my hospital in staff, which I think most of them are due to staff exposure. We had little outbreak in our virology lab, for example. But interestingly, an interim analysis by the Office for National Statistics is showing no higher risk for death from COVID-19 in healthcare workers compared to age-sex matched general population. And I'm taking that as vindication for our approach to PPE. In other words, PPE does seem to be working. So what's the legislation around all this? Well, the fundamental law is the Health and Safety at Work Act, HSAWA 1974. And there's a general duty on employers there to their employees. It should be the duty of every employer to ensure, and this is the key bit, so far as is reasonably practicable, the safety and welfare at work of all employees. There's also a requirement on employees as well, which is often not understood or appreciated, and that's the duty on every employee while at work to take reasonable care for their own health and safety, and also to cooperate with their employer's requirements. So, you know, if your employer gives you a mask, you need to wear it. Now, we all seem to kind of jump towards PPE as the first thing to think of, but actually, from a health and safety perspective, PPE is right at the bottom of the control measures. This is a really nice little graphic from NIOSH, and National Institute of Occupational Health, in National Occupational Safety and Health in the States. And you can see right at the top, most important is elimination, physically remove the hazard. And to some extent, we've been doing this by screening patients, and if they don't need to come in and they're positive, then we keep them out of hospital. And certainly that was the situation right at the beginning of the COVID-19 outbreak. There was initially a suggestion that patients should come to our casualty department and get screened there. And I thought that was a rather dangerous thing to do, because why would we want to bring potentially contagious people to come and get swabbed sitting in a waiting room with perhaps several hundred other people? So we set up locally an arrangement with a provider who went around and visited people. So if someone felt unwell, they rang up the local public health unit. They were then sent, people then went out to visit them, they swabbed them, and the swabs were brought into our lab and we tested them. So that's one element of control, elimination. But there's only so far you can do that with healthcare, otherwise you'd have no patients and it'd be rather pointless. So the next bit then really is of any suitable, anything we can do in hospitals is engineering controls. And that includes, very importantly, shifting air around in clinical areas. So clearly there's lots of good airflows in operating theatres, but actually there's a lot of procedure rooms where the airflow is quite poor. And part of the thing we've found in preparing for COVID and during the COVID is how hit and miss some of our ventilation systems are. And in ward areas generally, actually it's not great at all. And I think that's something that we have to learn for the post-COVID era. When we're talking about designing new hospitals, we need to work out what kind of air ventilation engineering systems we have there to really tackle the risks of infections which are transmitted through a respiratory route. And even before we get to PPE, there's another level, there's administrative controls. And this is really trying to make sure that potentially infectious contacts are minimized as much as possible. So we've been doing that throughout the NHS by really shutting down on non-essential inpatient work. GPs have been doing this as well, of course, by doing remote surgeries. And this is really very important and very helpful. And as we move into the restoration phase, it's going to be, I think, more and more important. So I've been getting a lot of questions recently, for example, how to run ophthalmology day case surgery. Most cataract surgeries in patients over 70 years of age, we want to make sure they don't catch infection in hospitals coming for their cataract procedures. So an administrative control there is one thing that we've been thinking about, is having patients wait in their cars in the car park until they get a phone call asking them to come up for their surgery, and therefore making sure that patient contact is minimized as much as possible. But finally, we get down to PPE. That's what we're going to talk about tonight. So, following the Health and Safety Work Act, there is the Personal Protective Equipment at Work Regulations 1992. And in a sense, this allows less wiggle room than the Health and Safety Work Act. I've mentioned the Health and Safety Work Act requires employers to do all that is reasonably practicable. That's less apparent in these regulations, but the word there is every employer shall ensure that suitable personal protective equipment is provided. And actually that raises the point here that unless such risk has been adequately controlled by other means. So that goes back to the hierarchy of controls I mentioned earlier. So what is the risk? So in order to understand what safety requirements we need to understand what the risk is. And that, unfortunately, that's not really completely established with COVID-19. Most national, international bodies are talking about droplet spread, and I'm sure that's mostly right. So we can get that direct transmission through droplets by standing close to someone who's coughing, and they cough out these large droplets, which if they hit you in the face, if they get into your mouth and nose or in your eyes, then there's a possibility of infection. But the question about aerosol transmission is still one that's a hot topic. And that's much more problematic, because you can see if someone's coughing and you can keep away from them quite easily. But if aerosols are a major route of transmission, then the nature of aerosols being hanging around in the air, maybe not the person that produced them is not even left in the room, then I think that's really difficult to control against. And then the other one is indirect transmission through fomite spread. And again, I think this is something that may be relevant. Feces are, well, there's certainly virus in feces. Whether it's important is another matter. Aerosols have a kind of definition of being less than 5 microns in diameter, but actually it's a bit more of a kind of gradient approach there. I mean, there isn't a quick, it's not so dichotomous as this definition would suggest. And they create the potential for airborne transmissions. Now, if you look at the Public Health England website and guidance, you'll find a list, this list of aerosol generating procedures. And it's one that is mostly been, predates COVID-19. But you will know about, I'm sure many people know about various professional groups suddenly deciding that what they've been doing quite happily for many years is now a dangerous aerosol generating procedure. And I'm sure in some circumstances they may well be right, but I think there's probably a degree of overcaution in some of that. But who's to say that's a bad thing? But if you were to look at this list, you might think, well, this is fairly definitive. But actually, it isn't. And this is a very nice table brought, I downloaded from a document from the Speech and Language Therapy College. And it compares different countries' approaches to aerosol generating procedures. And if you look at this in detail, you'll find that there's very little agreement across the various countries, New Zealand, Australia, CDC, WHO, about what constitutes an aerosol generating procedure. And I think post-COVID, again, we're going to have to do some very substantial work to really trying to nail all this down and decide what really is and isn't an aerosol generating procedure. So clearly aerosols, well, clearly airborne route, respiratory transmission is the major thing. And therefore we've got to try and protect the airway. And so the major routes are respiratory protection with either masks or what are known as FFP3. And everybody starts talking about FFP3 now as if they know what they're talking about. But actually these are quite a wide range of devices, ranging from this disposable half mask in figure 1 there you can see, to something much more substantial and solid. Now the figure 1 mask is disposable, the other two there, figure 2 and figure 3, are reusable. And we've got some of these going in our ITUs and in our emergency departments admission units, because we really wanted to make sure our frontline staff were protected. So there's some technical descriptions of respiratory protection. Surgical masks come in 2 major types, type 1 and type 2. And type 1 really isn't intended for use in a healthcare setting. It's not really reliable. So we should all be using type 2, and in particular type 2 R masks, the R standing for fluid resistant or fluid repellent. And these are probably the important thing for most clinical procedures, unless there's a aerosol generating procedure going on, in which case you really do need to be using an FFP3 or potentially an FFP2 device. And these vary really by their filtering efficiency. So FFP3, as it says, are 99% filtering efficiency. FFP2 are equivalent to what is normally described in America as the N95 mask. I think the N95 has a 95% filtering efficiency, so it's pretty much equivalent to an FFP2. Now, European Commission came up with a recommendation a few months back, asking notifying bodies, regulating bodies, if they can come up with agreements about what a PPE suitable for use during the COVID-19 emergency might be. And so the British Standards Institute have come up with some things for UK manufacturers. But to be honest, I've not seen anything coming out as a so-called COVID mask yet. So what's the best thing to wear? An N95 or FFP2 or a surgical mask? And actually the answer is no one knows. we've got some recent, a recent meta-analysis looking at protection against flu, and the evidence there suggests that surgical masks are just as good as N95 FFP2 or higher for most healthcare circumstances, apart from aerosol generating procedures. Now, there's a paper that's just come out in Lancet, which again is a meta-analysis. But this is a meta-analysis really of case reports or anecdotes, so I'm not really sure it's a great piece of work. But there was a suggestion there that possibly N95 or FFP3 masks provided more protection than surgical masks. But as I say, I think that's quite a flawed paper, and I'm not really putting any reliance on that. There's another piece of legislation which is also relevant, which is the COSH regulations. And again, we have to look about what that recommends. Health and Safety Executive, taking into account the COSH regulations, recommends the use of an FFP3 device for use against viruses in aerosol generating procedures. But they do recognize there's a shortage of FFP3 devices, and so they are allowing FFP2 in this country as an alternative. The problem with FFP3 and FFP2 is fit testing, because both of these devices require fit testing to be carried out. So what this is a test for the leak proofness, effectively, of the device. And so that when you breathe in, you shouldn't be breathing in contaminated air coming through the gap between your face and the device. And so the requirements really from HSE is that anybody wearing an FFP3 or FFP2 device should have fit testing carried out before they use it in action for the first time. And more than that, it should be that fit testing should be repeated whenever there's a change either to the device that you're using or to the person who's wearing it. Now, there are two major types of fit testing. One is qualitative fit testing, the other one is quantitative fit testing. The problem with both of these things is that it takes a lot of time, and it also, with the quantitative fit testing, destroys the device. And I think actually you can't really use the qualitative fit testing either. So if you're doing a lot of fit testing, you're using a lot of FFP3 or FFP2 devices. And what many people have encountered over the last few months is very hit and miss delivery of FFP3 devices. To illustrate this, we got given 4,000 FFP3 masks, which were a completely different model from the ones we've been carrying out fit testing for. We've got 3,800 frontline staff who need fit testing. So you can imagine that we might do all the fit testing and then only be left with 200 devices left. So that was clearly impracticable. And we've really faced a dilemma about whether we give out the FFP3 devices without fit testing or try and do some fit testing. And it really has become very difficult indeed. Over the last few weeks, we've had 9 different FFP3 devices in our hospital, all theoretically requiring fit testing. And it's really quite impossible to do all that. So that is really one of the major issues that we've encountered over the last few months. Moving on to other PPE aspects. So there's eye protection, there's some kind of basic body protection, which is gowns or aprons, and then there's gloves. And again, PHE have come up with a detailed table of what we should be wearing at different times. So, for example, if you're just providing care to someone who's shielding, then the only thing that's really required is some kind of surgical mask. And I think what they mean by that is a type 1 surgical mask. However, if you're providing anything other than care during aerosol generating procedures within a hospital setting, then you should be wearing a type 2R mask and also eye protection, a plastic apron and gloves. Finally, within England, within the PHE recommendations, with aerosol generating procedures, then you should be using an FFP3 respirator, as well as long sleeve gowns as well. Now, again, there's international variation. ECDC, European Centers for Disease Control, WHO, and Centers for Disease Control in the United States all have subtly varying differences or recommendations. And the problem with all of this is that it doesn't inspire confidence. Why are we doing something differently from what WHO recommends? Is it because we feel there's a definite clinical advantage to this? Well, in the absence of if when we start using surgical masks instead of FFP3 or N95 devices, people get a bit nervous about that. And I think it does require a lot of explaining to frontline staff that what they're using is perfectly acceptable and good quality safety. But life is difficult sometimes when you're doing that. So moving on to the last slide, really, PPE, it has a place, but we shouldn't be thinking of it as PPE alone when we're talking about controls against infectious diseases. We really need to make sure that all the other elements are in place as well. Unfortunately, the evidence for what is optimal PPE is weak, and that is reflected in varying national recommendations. As I mentioned before, I think surgical masks or type 2R masks are probably sufficient respiratory protection, except for aerosol generating procedures. The delivery of FFP3 devices in this country over the COVID time has been very problematic, and that's a polite way of putting it. And I think it has led to a lack of confidence and a lot of distress. The other issue then is how HSE has responded to all of this. They've been very rigorous and rigid in their approach. And despite requests for them to ease off the requirements for fit testing, they've maintained that requirement throughout. And it's interesting to know what might happen as a consequence of that. We're kind of in uncharted territory at the moment. So that's it. I think that's my presentation over. So thanks very much for your attention, and hopefully there'll be some questions.
Thanks very much, David. Do you want to put the screen back so people can see it?
Yes, good point, yes. So stop sharing. Yeah, brilliant.
Yeah, thank you. That's a lovely talk through the practicalities of PPE. I've had quite a few questions. Let's start with the masks. Everything you've said about wearing a mask relates to the healthcare worker, and that's to prevent the healthcare worker from inhaling virus particles. What about the other side of the equation, and how useful are masks on the patient?
Right, okay. So there is some evidence for effectiveness or efficiency in patients wearing masks. They do get some protection. The figures I've seen estimate that the protection for patients wearing masks seems to be substantially lower than for healthcare workers wearing masks. And that may reflect the patient tolerability of masks. I mean, masks, many people find them difficult to wear even when they're doing it professionally. But it doesn't take too much time walking around hospitals looking at patients wearing masks or in the streets to see that mask use is very variable and sometimes very ineffective. The other issue I didn't mention really was about FFP3 devices and valved masks. And I saw a couple of people today wearing an FFP3 mask, a couple of patients or people out in the street, to be honest, with valves on them. And the issue about those is that if the person wearing that device is infected, they're exhaling infected air, and the valves in them allow that air to go out unfiltered. So there is a problem. We shouldn't really be having FFP3 devices in either for patients or for staff which are valved.
Okay, so for people wandering around the street, I've had 2 or 3 people ask, and indeed there are learned bodies that are recommending that we should all be wearing masks.
Yeah, so the evidence for it is poor, I think, and that could either mean that it hasn't been studied properly, or that actually the significance of mask wearing as a public health measure is rather minor. And I guess the answer is we don't really know. I know that in many countries around the world, particularly in Asia, mask use is a fairly common thing, not just in COVID, but whenever you have a cold or the flu in those countries. It's never been that sort of thing in this country. It's been quite a remarkable change in practice, I think, over the last few months. I mean, just in January, February, if you saw someone wearing a mask in the street, you'd wonder what was wrong with them and try and keep clear. and now people wearing them to protect themselves. It's a complete change in mentality. Whether it does anything, I don't know. Do you wear a mask when you go shopping?
No, I don't. No, no.
No, me neither.
Yeah. What about, I mean, patients who we diagnose with COVID, ideally you put in a side room, and
Yeah.
if you haven't got enough side rooms, you put them in a COVID ward. Is there evidence, or is it recommended that patients in a COVID ward in whom you've diagnosed infection should be wearing masks for the protection of the healthcare workers?
I wouldn't mind it. I mean, I'm fairly agnostic on this, to be honest. As I wouldn't mind. I wouldn't mind it, except for the practical problem that we may well run out of surgical masks for the healthcare workers to wear. Right. I think that really is the question, the problem or the challenge that I would have, and that's why I've been discouraging widespread mask use by patients within my hospital. I'm concerned really that our stock would be used up and we would end up with healthcare workers unable to be protected. And we saw what happened, particularly in Italy, when that happened, when that situation arose. Right. There were numbers of healthcare workers who died as a consequence of that.
Okay, two people have asked about wearing masks in lab stuff, where they can't social distance because of the way the machines are set up.
Yeah.
You recommend that?
Yeah, absolutely. In fact, really early on, our virology lab is fairly crowded. Again, you can't social distance there. And I was a bit concerned about this. So I took a whole load of masks in there and suggested people wear them. And a few people took it up, others didn't. But then virtually everybody stopped wearing them within a couple of days. And then we did have a little flurry of infections, and now more people wear them, but it is still a bit hit and miss. So it's interesting, even knowing that people have had infections in the environment in which you work, has varying impacts on people's enthusiasm for wearing masks.
Okay.
Interesting. Do you wear that? What about in your laboratory then? Do they?
I haven't seen anyone in our lab wearing masks. Yeah. No. So fit testing.
Yeah.
I admit to never having seen the process done.
Right.
Maybe I've misunderstood it, but I assume this is a personal test so that the mask is adjusted to the contours of the particular individual.
Right. Okay. So there are two types. I mentioned the two types of fit testing: qualitative and quantitative. The qualitative one, basically, you put the FFP3 mask on your face, and then someone puts a kind of big paper bag over your head with a kind of clear window in the front. And then they squirt a bit of aerosol into that. And it's an aerosol of either something very sweet or something very sour, something that you would taste if it gets into your mask or gets through your mask. So that's the qualitative fit test. And actually one of the problems that's arisen with fit testing over the last few months, apparently has been a shortage of that kind of test chemical. Now, we use in Leicester a quantitative approach, which is, I think, a better standard. And what you do there, you kind of puncture the FFP3 device before you put it on the patient on the person's face. There's a little tube that goes into that puncture, and it allows you to measure aerosol droplet or particle contents in the air that you're breathing in outside the mask, comparing it to the number of particles, the concentration of particles within the mask, between your mask and your face. And so that ratio is calculated. The machine calculates the ratio and tells you whether or not you've got a good fit or not. So what you're looking at is evidence for leaking in both of those testing. You're looking to see whether there's any leak between the mask and your face. Now, there's very wide variation in the ability for masks to fit. The best masks that we've come across have had up to 80% success rates. But that still means about 20% fail. And then you've got to try and find a mask which fits them. And oftentimes you get people who just, you can't find anything that fits them. And that's not even without even talking about people wearing beards or other having beards or other things which would prevent any mask from working properly. So in some patients, you then have to think about, well, can you have a powered hood? So basically, it's a kind of it's a bit like a space helmet with that's drawn in through a filter and goes into you breathe that in. And then I mentioned about the full face visors that we've got in our intensive care units, our emergency departments, and so on. And these are really excellent. They're a bit like full face diving masks. You breathe air in through filters, and the filters last for, I think, 6 months. So these are masks that are reusable, and all you have to do is clean them after every use, store them away, and use them again the next day. And these tend to fit a much wider range of people. Much more expensive upfront cost, but actually, I think over the whole outbreak, they'll probably work out to be a cheaper option. But if you have glasses, they're no good because you can't wear them you can't have glasses inside. But they're good for people with beards or other reasons why they can't have standard disposable FFP3s.
And the standard FFP3s, once you've fit tested it, how long can you wear it? Does it work forever, or do you?
So the paper FFP3s, they're single use only, so sessional use. So you go and work a shift, you take it off, you go for lunch or something else, and you throw it away, you get another one. Well, that's the intention. There has been concern that we may run out of these devices, and so there has been consideration of how they can be decontaminated and reused. I think that's, if we were doing that, we'd be in real dire circumstances. And so far, we haven't had to do that. But who knows where we might be in a few months' time, depending on whether we get a second wave or not.
And specifically, what is your opinion on the homemade masks?
Right, now this is really interesting. So again, there's very little evidence to support these as being effective. There's only one study, randomized controlled trial, that's ever been carried out looking at cloth face coverings, as I prefer to call them. And that was in Vietnam, published in about 2015. And it was a study carried out in healthcare workers, obviously in the pre-COVID era. And it was looking at risk of infections in healthcare workers. And the treatment arm was a proper 3M mask. The control was anything that you wanted to, and another treatment then was a cloth face covering, and it turned out that the healthcare workers using the cloth face covering had more infections than the standard control arm, which included some people wearing masks but not the 3M device. So, you know, in public health, it's very important that when you think about an intervention, it's not just thinking about, well, this must be better than nothing, because actually what you do may actually cause harm. So we really should be very careful about saying people should be wearing face cloth coverings with the assumption that it's better than nothing, because that may well not be the case. And there are a lot of reasons to think about. If people wearing face cloth coverings are going out and doing things that they otherwise wouldn't have done, potentially exposing themselves to greater risk, and if those face cloth masks aren't working effectively, then what you're doing is increasing the risk of infection to people, and therefore increasing the likelihood that more people will become infected. So I think you have to be really careful about promoting these. I'm very hesitant to do that.
One very specific question, but it's an interesting one, around dental workers. My question is, which sort of mask do the dentists and the dental nurses wear?
Yeah.
The question posed is that dental workers will have been exposed to COVID before the epidemic was sort of fully recognized. Mm-hmm. I don't think there's any epidemiological evidence that they were more likely to get infected. So to imply that they were using were actually efficient.
Yes. So again, this goes back to what kind of risk are they exposed to? Now, as you say, they will have been exposed undoubtedly to people who were infected at the time of the dental surgery, because we know there's quite a reasonable amount of asymptomatic or low symptom disease or infection. But dentists do wear respiratory protection of a sort as a routine, but it tends to be of the kind of surgical face mask type rather than an FFP3 device. And the other thing is when dental work is carried out, do the devices that they use, the high-speed drills, the suctioning, do they create a significant aerosol potential? And again, I think that this is something where we talk about aerosol generating procedures as a kind of either it is or it isn't. And I think the truth is that there's a gradient of levels of risk with aerosol generating procedures, ranging from the hardly anything at all to the really very significant and highly dangerous. And I suspect that probably the dental risk of aerosols is towards the lower end of risk, and that surgical masks in that case may well be sufficient to protect dentists to a reasonably safe extent.
Okay, let's move on to aerosol generating procedures.
Mm-hmm.
3 questions. Taking a throat swab to diagnose someone with COVID, what sort of a mask is appropriate for that? Lung function tests, how have you handled that in your hospital?
Right.
And endoscopy.
Right, okay, so taking a COVID swab, assuming that the patient isn't taking it themselves, which I think that's some of the things we've adopted. So we kind of shove the swab through the car window and then watch them do it with the window closed up. But I think taking the swab otherwise, I think a surgical mask and eye protection and gloves and an apron is sufficient there. For what did you say was the second one? The
lung
function test. Yes. So I closed down the lung function lab during the COVID epidemic. I told them not to bother. I thought it was quite dangerous, and I was surprised by the lack of pushback. They were quite happy to take that advice and stop doing it. And we're still, we've got one of our rooms is acceptable for lung function testing, assuming it's an aerosol generation procedure. So we're doing it in one room. So we've resumed lung function tests, but to a much lower level of activity than previously. And then endoscopies is an interesting one. The PHE guidance has been modified to include upper GI endoscopy as a potentially aerosol generating procedure if there's open suctioning going on during the procedure. And I can understand that to an extent, but I think again it's probably not the most dangerous of AGPs. There was also concern that colonoscopy was an aerosol generating procedure as well because of the actually quite a high load of virus in feces, as I understand it, and also prolonged. My understanding is that there's prolonged excretion of virus in feces compared to respiratory. You'll know more about that than me. But so the question then, well, is that an aerosol generating procedure? And I suspect, well, my view on that, that must be very low risk. But bear in mind where these procedures take place. And what we found about our endoscopy units was actually the ventilation in there is really very poor indeed. So these are procedures that if they are generating aerosols, we're not dispersing that aerosol quickly. So yeah. the mechanical, the engineering approach hasn't been properly implemented. So going back to that hierarchy pyramid, we're relying on PPE entirely in those circumstances, and really we should look back at the engineering controls and beef them up a lot.
Right. Someone's written in saying, what do we make of the Health Protection Scotland review of AGPs? I don't know if how theirs differs from Public Health England.
Well, so this was the one, if it's the one they're referring to, I think, is the one that was published in November last year. And so this obviously pre-COVID, and it is the one that PHE pretty much based their AGP list on, at least initially.
Specifically says that only high-speed surgical procedures in the head and neck are AGP and not the wider body.
Yes, and I think that's right. Okay, so that may be a later a post-COVID variation. And again, this is a kind of discussion we had early on, for example, with orthopedic surgeons. They use high-speed twist drills when doing work in orthopedics. But the evidence is that virus in blood is very low level. And from a point of view of COVID-19 contamination, I think the aerosols, any aerosols produced by those drills is not significant. So I think the head and neck, any surgery involving the respiratory tract, so that's head and neck, but also thoracic surgery as well, is potentially aerosol generating. So I would be very happy to support that. And I think, interestingly, ENT generally, looking back on it, I suspect they've probably been exposed to quite a high risk for some time. You know, they look down people's throats, and my recollection of this is that they don't wear masks routinely when they're doing that. And I think a surgical mask, at the very least, should be the standard of practice for ENT surgeons when they're carrying out inspections, even just peering down people's throats. Now, the question then is, well, what about GPs or people taking throat swabs in practice? And you start going down a kind of slope then of where you need to stop. I think it's quite a difficult question to answer a lot of the time.
Yeah. Okay, I'm getting messages that we need to be thinking of wrapping up. So I've got three, what I hope are fairly straightforward questions with straightforward answers.
Okay, keep it short.
Laboratory staff handling blood samples, what PPE is necessary?
So probably from blood, the risk from blood I think is very small. Probably the greater risk is from the outside of the test samples. An interesting study published a couple of years back, during the Ebola crisis, they coated the outsides of test tubes with a powder which glows up, and a glow germ powder which glows up under ultraviolet light, and then some experienced BMS were carrying out assays or tests using that from those samples, and there was widespread contamination of the lab environment with that glow germ powder. But they also spiked the samples with a phage particle and found very little contamination with that phage outside the assay material itself. So I think it's not the contents; it's the outside which is probably more of a risk. So, but I think that risk is adequately addressed by wearing gloves when handling those tubes.
Thanks. Okay. People wearing masks for long periods of time, is there any evidence that that impairs oxygen flow?
Oh goodness, I don't know the answer to that one. I think part of the testing procedure of the BSI standard talks about CO2 retention inside the mask. But I've had no idea about whether that leads to any appreciable desaturation in the wearer. I have no idea. I can't answer that one, so I'll look that one up for myself.
Right. I've saved the really political question to the very end.
Excellent.
Does 1 unit of PPE equal 1 glove or 1 pair of gloves?
Well, we only have one mouth, but you obviously everybody has 2 hands. So I think one glove is fine if you lost a hand, or if you're a single-handed practitioner. But
as far as the government is concerned, is it not true that 1 glove was 1 item of PPE?
Yes, apparently that's the case. Yes, when Matt Hancock counted, he counted 1 glove per hand as was one item of PPE. I mean, that's a ridiculous thing to be honest, isn't it? I mean, it's one of these things that it's a stupid thing to say politically, because it's only going to come back in a bad way.
Yes, right. As a number of government statistics are indeed doing.
Yeah.
Okay. So thank you very much indeed.
Okay.
You've given us, responded extremely well, and we had loads of questions. I apologise if I haven't asked everyone's question, but I think most of the issues that people were concerned about. So with that, I'll thank David very much on everyone's behalf, and see many of you next week. Goodbye for now.
Okay, bye-bye.
Bye-bye.